get started, okay?
Absolutely.
All right. All right. So it is 2:01 now. All right. And others will join in as we move forward. So Dr. Ann
Perfect.
Partridge is a professor of medicine at Harvard Medical School and is the Eric P. Weiner Chair in Breast Cancer Research at Dana-Farber, Vice Chair of Medical Oncology, Director of the Adult Survivorship Program, and founder and director of the Program for Young Adults with Breast Cancer at Dana-Farber. As a medical oncologist, she focuses on the care of adults with breast cancer, and she has a particular interest in the psychosocial, behavioral, and communication issues in breast cancer care and treatment. The title of her talk today is Breast Cancer and Fertility: What We Learned from the Positive Study. I will serve as the moderator, so please place your questions in the chat and I will verbalize them for you at the end of the session, or you may unmute yourself and ask directly. So, Dr. Farber, thank you for being here.
Sure.
Sorry, Dr. Partridge, sorry.
I knew what you meant. Good person to confuse me with. Okay, I'm going to put in slide show. Is that the good view?
Yes, it is.
Okay. So thank you for having me. Near and dear to my heart is speaking with all of you who are on the front lines of this issue. So some of the stuff I say won't be, when I talk about how much people care about fertility, I often am talking to oncology groups, and they often are saying things to me, which I'm sure all of you have heard of, a doctor said to them, well, you already have one. And yeah, we all know that, I'm a second child, so I resent that in particular. But we know that we don't want cancer to take those kinds of life choices away from our patients and their families. So what have we learned about this and from positive in particular? And we'll go through that. And I don't have particularly sexy royal disclosures, but I do write a survivorship chapter for Up to Date. So when we think about our young adults with cancer and breast cancer specifically, they face particular challenges, not just the stuff at the top, the chemoendocrine and local therapy, concerns and decision-making that challenges all breast cancer patients. They have to think about whether they need things, and especially early breast cancer patients where it's a multidisciplinary approach. But they have everything on the bottom, genetics and the emotional toll. We know it's harder on our younger patients. The body image, the sexual health, the role functioning, much harder to go through a breast cancer when it's like not normative compared to your peers. You don't have hot flashes when you're 30 unless you're going through a breast cancer or IVF sometimes. But, as we know, and so you guys in general, people dealing with fertility are also dealing with this kind of not normative thing that people of this age are going through, which is being infertile, because most young adults are also worried about, not getting pregnant, not getting pregnant. And fertility and premature menopause, therefore, for this group of patients is such a critical issue because our treatments and the time it takes to get them can either threaten and or negate their ability to have future biologic children if we're not paying attention to it, and sometimes even when we are. So we focus on this a lot. And we have surveyed, as have others, young adults with breast cancer about their perceptions of this. And years ago, we looked at over 600 women through the Young Survival Coalition who were average age of 33. And these women were average 2 years out from diagnosis. So maybe a little recall bias, but nearly 60% said that they had had substantial concern at diagnosis about their fertility after treatment. And almost a third of those patients said that their concerns had influenced their treatment decisions. Now, on this survey, we didn't ask them how or why, was it they took chemo or not? Did they take less chemo? Did they not take their hormonal therapy? We don't know the answer to this. Years ago now, too, we started a cohort to focus on young women. We call this the Young Women's Breast Cancer Study, based at Dana-Farber, but it's at a number of sites in North America. We enrolled women 40 and under at these sites, both the community and academic sites, and we've studied disease treatment issues as well as psychosocial behavioral and survivorship issues. And the primary outcome that we initially focused on was fertility concerns, and now we're looking at fertility outcomes. And I'll show you some of these data as we go through this in the context of fertility, babies, as well as the positive trial that we'll talk about in the results. We accrued over 1,300 patients. We follow them very, very closely. We have blood, tumor, and lots of info on them. And we've even done some sub-studies recently on, within this cohort, on people who had a live birth and then what happened to them in terms of the birth as well as the peripartum experience. So when we first, as I said, we powered it based on fertility concerns, and my colleague Katie Ruddy, who's now at Mayo Clinic, led this analysis looking at prospectively. So these women were enrolled within 4 months of diagnosis on average, so no recall bias anymore. And we asked them, how did they feel? And this was all comers 40 and under. The average age of this group is 37, not 33. And in this group, 40 and under, about 38%, you can see there, said they were somewhat or very concerned about fertility at the time they were making their treatment decisions. Now, when we looked further at this cohort and asked them about what special steps, and remember, these people came on board between 2006 and 2016. So things were evolving, but it was after ASCO guidelines had come out. And I'm sure ASRM and others had guidelines around this probably before ASCO. And you can see here that while 68% said they discussed fertility before treatment, only 10% had taken any quote unquote special steps to preserve fertility. And obviously that's a lot lower than you would expect among the almost 40% who were very concerned about this. So trying to kind of mitigate that disconnect is something that we've spent time in the subsequent 2 decades focusing on. We have also recently looked, I did this with a medical student actually, and said, okay, now we know more about genetic testing. We know who in our cohort is a carrier of at least BRCA1, BRCA2, and some of the other highly penetrant genes. We don't know everybody, but most people have been tested over 95%. And we said, okay, among those who've tested positive, are those people different in terms of their fertility concerns than people who don't have a genetic predisposition? And you can imagine they might be different in some ways and not different in other ways. So we've, among the cohort within 1,000 or so, because we wanted all early stage patients, we found that of 11% who tested positive, most of them were BRCA1, BRCA2, and then a smattering of other types of genes in the rare P53. The median age of the carriers was slightly lower. And what when we looked at the carriers versus the non-carriers, very, very similar in terms of desiring more children after. And you know, when they were before diagnosis, although numerically it looks like the carriers want more, statistically that's the same. And they both went down after diagnosis. People changed their minds, you know, maybe they're thinking about another or one, or but they came down in a similar way, and there was no difference between that. So no big difference about the desire. Many people, as we know in North America, even though there's more testing, most people still don't know they're a carrier until after they get their breast cancer. So that's not that surprising. What was interesting was concern about cancer risk heritability was, of course, more common among carriers, as it should be, 74%. What's interesting is, this is, you know, maybe this is about the people not having babies or who don't have kids at all and don't want kids. But the fact that 26%, and our cohort is very much, there are a lot of people with children, 26% wasn't concerned about that among the carriers, which is interesting. And among the non-carriers, 36 were still really concerned about heritability of these cancers. And so getting better data for them, now that we're testing more and more kind of survivor data among non-carriers about the true risk of your child getting breast cancer or you getting a second primary, is something we've been focusing on, because we don't have good data in post the era of genetic testing and knowing who's a carrier or not. And then finally, we found that the same proportion of carriers and non-carriers were somewhat or very concerned about being infertile. That's kind of interesting. Not necessarily would we expect to see a big difference, but now that we have a little more data, and I'd be interested in hearing your thoughts on this, that maybe people with BRCA1 mutations might be just inherently less fertile by virtue of their mutation status and the biology behind that, based on Kutlik octase data and others. You know, when that gets out more to the public, maybe we'll, or if it ever does, or if it's validated more, maybe we'll see this change a little bit. And then also, interestingly, there was no statistically significant difference among the carriers versus the non-carriers in terms of using fertility preservation strategies. And remember, this is over a decade period of people coming on board where we've learned a whole lot, both about genetic testing, around PGD, around, thinking differently about this potentially for our carriers. We've also looked at, how people feel about fertility, not just at diagnosis, but over time. And this is looking at the cohort over time. And you can see that, the baseline, the denominator is going down. People stop responding to our surveys, and people have events like babies, but also cancer recurrence and problems or deaths, rare, fortunately not so common, but it happens. And you can see, though, that it's a survivorship issue. And I probably don't need to tell you guys this, but it's, of course, something that I find in the clinic. If I see a young woman who's very distressed on her hormonal therapy, especially, often it's, okay, she's having the symptoms, but really she's waiting to have her babies and she's upset about that. And you have to have a lot of conversations about that. And we'll talk more about that. We've also, in a large group, in conjunction with one of my colleagues, Matteo Lambertini, who's a breast medical oncologist in Geneva, Italy, looked at, what happens to people worldwide. And he's looked in population-based data around breast cancer survivors and the rates of pregnancy. And you can see here that even though breast cancer doesn't affect the diseases of, the organs of reproduction, like cervical cancer, where rates of pregnancy you'd expect to be lower after a diagnosis, the rates of breast cancer are the second lowest in terms of likelihood of having a baby, compared to things like leukemia and bone cancer and even ovarian cancer, which feels pretty shocking to me, among childbearing women. So it's breast cancer is one of those ones where we've always been worried about what the breast cancer might do to recurrence risks. And I think that's why that's there, not because people are necessarily so infertile, although that's probably part of it. We know that ASCO and others have created guidelines around this. And I highlight, to me, and this is again where I'm preaching to the converted here, but when I speak to oncology focused audiences, treatment doctors, I really, and other providers and the surgeons, before, things get on their way in terms of time, we really need to have multidisciplinary thoughts about what's the risk of infertility, of course, not from the breast cancer surgery, but from the potential systemic therapies, and communicate with the patient their desire or lack thereof for future fertility. And if they are interested, are they at risk for treatment-induced infertility, and what are the options, and get them very quickly to our repro endo colleagues if they want to pursue any of the things that you all know well in terms of options for potential preservation. And obviously think about the male factor and things like that. So we try to make sure we get the word out early and often around this and facilitate it, at least at our own institution, as I'm sure many of you do, and we can talk about that. The other big thing I think I always want people to think about increasingly is, if someone's a carrier, I always feel like it's my job as the breast medical oncologist who's just uncovered this and has to talk to them also about talking to their sisters and their family about who else might be at risk for cancer, thinking about the next generation. And, especially before they may stay fertile, but if they, are on the fence about it, and there's someone that even if they could get pregnant in the future, they're going to have to go through, and they would go through PGD later to try and select for embryos that don't have the genetic predisposition, then why not do it pre-treatment if they need chemo, even if they're not going to likely become infertile from it and still have potential ovarian function, which the majority of these young people will, even if that doesn't completely equate with fertility. The other thing I think we have to talk about up front so that we manage their expectations is, if they're planning a future pregnancy that they want to carry, the timing with regard to their fertility clock, as well as the risk of the disease and any treatment they need. And that's where the positive trial comes in a great bit for our ER positive patients. And I'll talk about that. And then if it's a hormone receptor positive disease, increasingly, we have pretty nice data that in a person who needs chemo in the hormone receptor positive setting, that ovarian function suppression, that means they're high enough risk to warrant kind of the best hormones we've got. And the best hormones we've got now are using, an OFS agent, a leuprolide, a goserelin, a triptorelin to suppress their ovaries. Why not do it through the chemo? It may not make their fertility that much better. If, I'll show you some of the data, and I'm sure you're familiar with it. But it might, and they can get their endocrine therapy started, and we have data that it's helpful from a breast cancer standpoint, and it doesn't hurt from a breast cancer standpoint. So it's not going to hurt from a fertility standpoint. So why not get going? Anecdotally, one of my colleagues who ran the SOFT trial, which tested the value of ovarian function suppression, said that they also have some data that the patients seem to tolerate the OFS and the hormonal therapy a little better when they start it with the chemo. And that's probably just common sense. If you're going through chemo, you notice the hormonal changes a little less than if you go through chemo or go just cold turkey into hormone changes and then get changed. So it's fascinating that that may be true anecdotally, at least too. These are some data that my colleague Phil Porvu put together for a really nice review, which has all cancer types, including pediatrics, around at least the risk of quote unquote infertility or subfertility in breast cancer survivors. Again, he's got everything else in there too, if you want to look at this reference, if you ever need to look it up. This is a little older, it's from 2018. So, take it with the grain, as we're always evolving. And again, amenorrhea at 1 year is often used as a proxy, which we know is not a perfect proxy at all. But you can see here that it's been clearly demonstrated that the greater amount of chemo and the older a woman is, the more both alkylating and anthracycline someone receives, the higher the risk of at least amenorrhea and likely associated infertility. We don't think things like trastuzumab add risk. Tamoxifen definitely, and now OS and AI, they definitely add amenorrhea for sure. OS 100% unless they break through. But we don't think that they directly impair the ovaries and that it's really the time it takes to get them and the age that's going on there. There's no biologic reason it would. And we are now collecting better data on rates of amenorrhea or menses when people come off those agents in our young women's cohort and elsewhere. But it does appear that it's a temporary situation, the amenorrhea, and that it's not a permanent knock. But of course, the time is ticking. And unfortunately, as I'm sure many of you know, or most of you or all of you, the OS doesn't stop the clock on the time ticking in terms of the ovaries. These are more recent data from our young women's cohort that Phil Porvu also put together and published a year or so ago. And I think what I want to highlight here is that, there's some small numbers, so you got to be a little careful. The rates of amenorrhea, of course, generally go up. And this is just treatment-related amenorrhea on the top at 1 year, and the bottom is 2 years. And of course, they go up with age on average. They go up with, the more aggressive alkylating agents, the longer regimens, like TH is much less of a hit than TCH, and the ACT is much less than TH. But the thing I want to point out to you is look at the 1 year rates, and the denominator changes a little bit, but not that much. Look at the 1 year rates and then look at the 2 year rates of amenorrhea and focus on the far right. The 2 year rates are much lower than the 1 year rate. And what that means is that the temporary amenorrhea is not a great easy way to judge whether or not someone will have menses again or future fertility. And we do that all the time. And then that's, not just bad for family planning, but it's also bad for contraception planning and switching people to an aromatase inhibitor. And we've seen that the hard way in both the literature and anecdotes and practice where, you must be postmenopausal, especially as a woman ages. And this is all 40 and under, but, the 48-year-old who has amenorrhea after, multi-agent chemotherapy, she still can probably get pregnant and have it going, the eggs are going out of business sale. So you have to be very careful and not just assume someone's postmenopausal. Again, I assume you guys all know this, so I don't need to be preaching to the converted. I know you know it, but I like to show you the data from breast cancer patients. These are just some of the more recent data from Matteo Lambertini's meta-analysis, where he looked at the use of the LHRH agonists in women with breast cancer through chemotherapy, a mix of both ER positive and ER negative disease from the largest studies that would share data. I think he included 5 of them worldwide. And you can see that there was a doubling of the premature ovarian insufficiency rate, a halving of it in people who got GnRH agonists through treatment. And then on the right, you can see that there was a doubling of the babies born almost, but note everybody was under 40 and it's a modest change. So I think even though statistically significant, I think we take this with a grain and don't assume that that's like, the end all be all for fertility preservation. And if we can get people to their repro endos, of course we do as medical oncologists. And then the reassuring thing, as I said earlier, is that the disease-free survival and overall survival for this was the same. And then more recently, there have been some updated data from one of the bigger studies that was included in that meta-analysis, the PROMISE GIM-6 study. We looked at long-term outcomes and controls versus the LHRH agonist through treatment. And you can see here that in long-term follow-up, there was no significant worsening of any breast cancer outcome from GnRH agonists through. And in fact, the interesting thing about panel C, if you look at that, the red is the control group, the green is the GnRH agonist group, and the C is the patients with hormone receptor negative disease. And this is pretty small numbers. So that is statistically not significant. Don't let it scare you. This is and 80% of these people had ER positive disease. So I would take that as it looks safe and something that we can do both to treat the breast cancer if they're ER positive and potentially preserve menses, maybe fertility in that setting. All right. What about the feasibility and safety of the pregnancy itself after cancer? Well, beyond what I just showed you, there are very limited data with our newer treatments and limited data beyond breast cancer. Now we give different regimens, PARP inhibitors, CDK4/6, immune checkpoint inhibition. And of course, there's reasons to be worried. We are actually petitioning the FDA. We have a meeting with one of our breast cancer focused people there at ASCO to try and get them to start to require this as part of, pharma and any kind of drug that wants to get registered in the United States. If you're treating premenopausal cancer patients, we should be measuring this. It's, they measure and put all these caveats up, but why can't we at least try and get some, at least surrogates for fertility and maybe an AMH or something else, recognizing the limitations of that. We also know that pregnancy after cancer treatment may be complicated by the treatment-related risks of the organ impairment, especially the heart if you got an anthracycline, the lungs if you got Taxol and had pneumonitis, the uterus if you were treated for a non-breast cancer. And so one of the questions that always comes up to me is, they need an MFM specialist? I obviously send someone if they develop heart failure or are tricky in terms of, their other comorbidities and very serious. But what if you're healthy, but you got an anthracycline? Does this person need an MFM? The answer is, I don't know. I don't think we know the rates of bad things happening later if someone was exposed in utero, exposed when they were younger to, potentially organ impairing things. These days, I've been kind of getting an echo in people if they got an anthracycline and following them clinically, but not always sending them to the MFM if everything's okay. And there are no great guidelines around this. So we're trying to put some together. What about the safety of the fertility preservation and pregnancy? I think, there's very little data here. We have to think about the major risks. You guys are more than familiar with the risks of both, miscarriage, prematurity, low birth weight, and multips. And then, there is a little bit of data on the use of assisted reproductive technologies following breast cancer. This was just one study from Europe that suggested that things look pretty good and that mean follow-up after conception, 63 and 50 months, no difference in breast cancer outcomes, and people are able to get pregnant. No big differences in terms of, except the ART group is older and, older and it's had more miscarriages. But again, not surprising and nothing, no earth-shattering science here. What about fetal safety? Are those babies at greater risk from anything? The data are population-based or not very granular or very small. When we look at these things, we see that, at least in PD survivors who have babies, who have lots of different stuff, endocrinopathies, lots of scarring if they gotten radiation to their bellies, the increased risk of low birth weight in that group, preterm births in those survivors. Big registry studies, though, have revealed no clear increased risk of genetic abnormalities, birth defects, or cancers aside from the hereditary syndromes in the children of people who were treated for childhood cancers. When we think about breast cancer survivors, some big population-based studies have been done. This one suggested that as long as conception was a year or greater after finishing chemo with or without radiation, there were no higher risks than the infants of women without cancer. And This is just detailing some of the more updated data that looked at that. And you can see that there's a little bit higher rates of low birth weight and preterm births in women who have babies after breast cancer, a little more small for gestational age, more C-sections. You guys could explain that to me, but really, no great signal for anything like congenital abnormalities or other, abortions, induced abortions, things like that, or preeclampsia. All right. And what about disease-free survival? You can see here, this is from Matteo's meta-analysis. If anything, in the registry and retrospective data, having a baby after breast cancer looks like it could be a good thing for the breast cancer outcomes. We all take that with a grain and worry about the healthy mother bias. Healthier women are more likely to get pregnant, be counseled by their doctors to be pregnant, have lower risk disease, even in the most well-controlled studies. Here you can see in the ER positive patients, they look to be doing just as well. And in the ER negative patients, they're doing even better. But again, we worry about the healthy mother bias. Is there something going on biologically, or is it all counseling? They're more likely to get pregnant. Again, another large study, more recent, having a baby within 5 years, they look as good, if not better, if they get pregnant. Same thing after 5 years. So these are the retrospective data. And so with all of that in mind, for years, I've been talking about this and saying, look, there's no clear worsening with disease-free survival or overall survival for pregnant versus non-pregnant groups. But the data are messy. We worry a lot about these things. And I want you to get as much endocrine therapy as possible. And if you have triple negative breast cancer, so hormone receptor negative breast cancer, I also want you to get through that period of highest risk recurrence, that first 2 to 3 years, when really nasty cancers blow back and it's terrible to have a pregnancy and metastatic breast cancer. From a medical, legal, ethical, and these days it's even more tricky depending on what state you live in the United States. And of course, if you have ER positive breast cancer, I wanted you to get as much hormone therapy as you're willing to get for the patients, and that has always become a negotiation. And we've watched what happened in our young women's cohort. These are the data of, this is when I laugh about my research. So you can see here that I get to count babies. So you can see our cohort of over 1,000 people with early stage disease. Unlike prior studies where you didn't know whether someone wanted to get pregnant or not, or whether they were even attempting, we've actually measured that every 6 months for the first 3 years, annually afterwards. So we know if you were interested in having a pregnancy or not. And then we looked at when people were trying, and this is over the first 5 years. So you can see that 34% of those interested tried over the first 5 years, and on average, and of those not interested, 1% tried. So even though they're not interested at the beginning, those 4 people at some point tried to become pregnant. So what we found when we looked in, again, the first 5 years in our young women's cohort is that 108 women reported at least one pregnancy in that first 5 years. About 70% of those who attempted to become pregnant became pregnant. Some who weren't interested and or didn't attempt became pregnant. So, the flip side is the contraception. Only 32 patients used infertility treatment within this cohort within that first 5 years of 1,000 people. And again, 362 who were interested. And 75% of them had successful pregnancies, they reported. And the majority of people who became pregnant had ER positive disease. Again, not surprisingly, given how we have counseled people around trying to get at least 5 years of endocrine therapy. So it's a really tough conundrum for all of our patients who want a baby, but particularly for the patients with ER positive disease. So along comes the positive trial. And these were presented in December, and they were just published in the New England Journal. And I'll just show you the data and we can talk about that. So what we did was we said, okay, we want to deal with this clinical dilemma. We came together literally around the world. So 20 countries, 4 continents. I think there were 120 centers. It was paid for by, in the US, our government, through the NCI and the Alliance for Clinical Trials in Oncology. Around the world, it was the IBCSG and a lot of cobbling together of different countries and groups, because of course there's no big pharma company detailing this. It's a labor of love, so to speak. And premenopausal women who wanted to become pregnant, they had to be 42 and under. They had to have taken at least 18 months of endocrine therapy and no more than 30 months. This was because the judicious oncologist and patient wasn't comfortable with anything less than 1.5 years. And because when I would say it, I would say you have to take at least 3 years because 1 year of tamoxifen gives you 10% risk reduction, 2 years of tamoxifen gives you 30% risk reduction. Let's at least get you to 3. And then maybe you're getting as close to the 5-year 50% risk reduction. So at the 30 months and up from 18 to 30 was kind of a compromise and an experiment to say, okay, if people like Anne are saying get out at least 30 months when you're compromising, let's make it sooner so those women have something to, and we also, because it's really an experiment, not the standard. And then the other piece we said was, this is always a compromise for people, but we also know that the risk of recurrence with ER-positive breast cancer, the hazards are pretty stable for the first 10 to 20 years. And, that was a little bit of, when we see more recent data from our big Oxford overview, we said, why are we forcing these women, most of whom will be cured, to put their lives on hold when they want babies, when we're not sure that taking a break at 5 years after they've gotten that full 5 years is any better than taking a break between 2 and 3 years or 1 and 2 years in terms of their hazards of recurrence, because at least without taking a break, the hazards are the same. And so that's why we came up with this. They could have had chemo. They were allowed to use fertility preservation prior to study, on study, and they had to have no clinical evidence of recurrence. And what we did was a planned interruption within 1 month of trial enrollment. They had to have a 3-month washout to get the endocrine therapy out of their system, including the LHRH agonist if they were on that. We supported a 2-year attempt for pregnancy, so conceiving, delivering if you got pregnant, if you were, in full, breastfeeding, including that 3 months washout. If there was no pregnancy by 1 year, we recommended strongly that they have a fertility assessment. That wasn't mandated. This was literally a very practical study done around the world. And then we strongly recommend resumption of the endocrine therapy after pregnancy to complete the planned 5 to 10 years that was recommended by their oncologist based on their risk, their preference, their tolerance, the usual. And then long-term follow-up is what we're doing. So we just reported out the approximately 3-year data, which is 5 years on average from diagnosis for these women, but we're going to follow them for at least 10 years from now. So here are the key patient characteristics, really important to note. Median age was 37, so this was an older mother crowd, as you might expect. The 43% were 35 to 39, 23% were the older range of 40 to 42. Excuse me, most were nullips, as you can, oops, sorry, let me get back to that. Most were nullips, 75%, but 4% had 2 or more. And then really important also, mostly stage 1 and 2. About 40% had no positive disease though, so it wasn't a completely wimpy group of disease. And 6%, 31 people had stage 3 disease. Here you can see the treatment patterns prior to enrollment. Most people had taken about 2 years of endocrine therapy. For most, it was tamoxifen alone, the SERM 42%. Some did it with ovarian function suppression, and then a smaller proportion with AIs. Most had chemotherapy, about 62%. And a smaller proportion with mastectomy than breast conserving surgery. Many probably wanted to nurse. You can see here, this is the punchline. We had set a pre-specified safety threshold of 46 events based on historical controls, and we had 44 total breast cancer events. So we were below the safety threshold, and therefore the positive trial was a positive study. 22 or half of those events were distant events and therefore associated with potential life-threatening experience ultimately. And this was at a median follow-up of 41 months. So, just about 3.5 years. When we compared this group to a calculated external control group from the soft text data, we wrote a paper about this control group because it's a way of getting a better control group than just using historical controls. We basically, when we had half the patients enrolled in positive, we looked at their characteristics and we matched them by key predictive and prognostic factors to the patients that matched them in soft and text. And then we did calculations to estimate using bootstrapped methods. Don't ask me to explain it in detail, but again, we wrote a paper I'm happy to share. And we created this control group analysis, and that was ready for when our data came out from positive. And you can see here that when that is overlaid, that the patients for breast cancer free interval, as well as distant breast cancer free interval, The control group looked the same, if not a little bit worse than the positive cohort. Again, all in women who we knew wanted to have pregnancies, and we knew they were disease-free. We knew they had ER-positive disease. We couldn't do a randomized trial, so this is kind of the best data that one could get, both for ethics and feasibility. What woman would go on that? Another validating thing from our data was that when you looked at the patients in positive, the same things that predict the risk of recurrence in other patients not taking a break predicted risk of recurrence in positive. So the more nodes one had involved, the greater the risk. The bigger the tumor size, the greater the risk, and the higher the grade, the greater the risk. A lot of other things didn't seem to predict risk. Fortunately, age didn't predict risk, which was interesting. What we also did was look at with a landmark analysis of people who hadn't had a pregnancy by 18 months and those who had. We looked at whether or not the pregnancy itself might impact on their risk of recurrence, not just the break. Everybody took a break, but whether the becoming pregnant versus those who went on positive who didn't become pregnant, whether or not anybody did any worse. And the bottom line is that the patients who got pregnant actually seemed to do better on average than the patients who didn't get pregnant. So of course there is some healthy mother biology potentially going on here, but you can't at all look at these data and say, oh yeah, having a pregnancy is like throwing gasoline on the smoldering embers and ignites a breast cancer recurrence, because we're seeing almost the opposite. And this is controlling for things like age, BMI, lymph node status, prior chemo, and prior age markers of risk. So really good news. When we looked at the babies born, we saw that 74% of the evaluable cohort, because not everybody were we able to assess, a substantial, almost 500 and 516 were in the full cohort. So not too many got lost. But this secondary endpoint, we were at 74% had at least one pregnancy. 70% of those were within that 2-year period where it was like sanctioned, not that people didn't keep going, for a total of 507 pregnancies. 317 had at least one live birth. That was 64% of all women and 86% of those who became pregnant. You can see here, at least one pregnancy on trial, at least one full live birth, and this is of the different groups. We had, of course, miscarriages, elective abortions, and one stillborn or neonatal death. The vast majority of deliveries were vaginal, and there were 11% of pregnancies had a complication, and the most common were hypertension and preeclampsia and diabetes. When we look at the offspring, 350 live births among the 317 women. There were 335 singletons, 15 sets of twins, and 62% reported breastfeeding, which is, I think, pretty interesting. We think about all these ladies having bilateral mastectomies, but obviously this is a select group. And they're not all having bilateral mastectomies, but a lot of them are. And then when we looked at the birth weights and we looked at the birth defects, there weren't any clear signals for harm in this group of patients and their offspring. All right, what about getting back on the hormones? So we were a little worried that people wouldn't resume their endocrine therapy, and we did a competing risk analysis of kind of what happens among patients. So cumulative incidence at 48 months, 8% had a cancer recurrence or death before resuming their endocrine therapy. There were actually 9 deaths in the study when we did the analysis. 76% had resumed their endocrine therapy, and 15% had not yet resumed their endocrine therapy. And this was, again, a median follow-up of about 3.5 years. Of the 79% of women disease-free at 2 years who had not resumed their, so the 79% of that 15% who should have resumed their endocrine therapy because they were beyond the 2 years, they were still trying to get pregnant, active or recent pregnancy or breastfeeding at most. So again, that's 79% of that 15% who hadn't gotten on or had a new problem. So it's a small proportion. And if you step back and look at adherence in the wider population and young people in particular, that's actually a small proportion. Remember, these people are on a trial though, and they're rule followers. They could have had a baby without going on a trial, and they chose to be part of this study. So in conclusion, and when we can talk, our young adults with breast cancer face issues which are unique to or accentuated by their young age. Fertility and babies after breast cancer obviously is the biggest one that's unique to their young age. Fertility and pregnancy are critical for these patients, not just at diagnosis, but in long-term follow-up and at diagnosis. I think along the way, we need to consider their preservation opportunities and have these discussions or help them to grieve their losses if it's something that's not going to be a reality for them. The risk of recurrence based on both historical data as well as now on the positive data does not appear to be increased by pregnancy after breast cancer, including a temporary interruption of endocrine therapy to attempt pregnancy, at least with the timing we did in positive. Again, long-term follow-up is needed though. We only looked at short-term and we don't know that we won't impact, on 8-year or 10-year outcomes. And then finally, counseling for these patients who are interested or want to become pregnant after breast cancer should begin at diagnosis and include all of these considerations as well as the psychosocial health of the young survivor. And of course, I know you guys know this too, and how this can really pull on the heartstrings for these patients. I don't know what I was doing there, so I'm going to escape now and stop sharing. Thank you.
Thank you, Anne. Thank you. That was amazing. Thank you so much. I have a question and then we can open up. So for the positive study, I saw stage 1, stage 2, you did enroll stage 3 patients, and you said that there was no difference in the outcome between the stage 3 and the early stage. Is that right?
No. So we didn't do a direct comparison
Okay.
of the different stages. And there statistically in our forest plot that we showed, the higher the stage, the higher, well, we looked at nodes and we looked at tumor size. And
Okay.
as one might expect, there was a higher risk of recurrence in the higher risk cancers, but no delta with regard to whether they got pregnant or not.
Okay.
Or whether or not they didn't seem to, when we looked at everybody, pregnancy itself didn't appear to impact on their outcomes.
Perfect. Thank you. And I think your data was pretty convincing that this wasn't a healthy mother effect. Like you said, the data has always suggested that maybe patients do better because the ones who are healthier choose to try to conceive. But the data you show suggests that really it's there's no harm. So
I think the one thing, it's not a treatment for breast cancer, right? That's also what it showed. There were similar recurrences. And so when I'm talking about this with people, I say, when people say, "Are you sure it's safe?" And I've seen so many consults before and after positive was coming out about this. I say, well, you're at risk for breast cancer recurrence. It could happen before, during, or after. I'm nice about it, but it's not a guarantee that you're going to be okay or that the pregnancy is going to be okay. As one of my repro endo colleagues said, and it's not a guarantee that your kid's not going to be a jerk either. I'm joking, but it's more like, what I can say is that it doesn't appear that this temporary interruption impacts at least on short-term outcomes with regard to the breast cancer, but that doesn't mean you still won't hear from it again during or after.
Mm-hmm. Fair. Dana, you had a question. Did you want to ask it or did you?
Hi, thank you so much. It's amazing what you've done. I have actually 2 questions. My first question is if you included patients that were in immune therapy or not, because I understand you evaluated to stop tamoxifen, but what happens with patients that are on like this immune therapy that I don't know how to say it in English? And that's my first question. Maybe you want to ask that one.
Sure. So any of the adjuvant therapies, we didn't say they couldn't get any systemic therapy. So there certainly could have been people who got immune therapy as part of a clinical trial, either as their preoperative or their postoperative therapy. Right now, around the world, there's no standard immunotherapy for ER-positive breast cancer in any ER-positive breast cancer setting. And so it would be unusual for someone to have gotten that outside of a trial. And then when we do that, and I'm not aware of any trial going beyond a year of immunotherapy. And so we required at least 18 months of endocrine therapy. So it'd be highly unlikely that that was still in their system, but they might have been exposed to it, number one. They also could have, as you said, gotten PARP inhibitors or gotten abemaciclib or another CDK4/6 inhibitor. That being said, again, those things would have been given earlier in the course generally of their adjuvant therapy. And then by the time they got to, remember, these people are very select, right? And oh, you didn't ask me this, and I forgot to say it, 43% of women used some form of reproductive technology while they were on study. We are currently breaking down what exactly they used. And that could be that they just used their products from banking before and then, use that to get pregnant. And that may be because of infertility, or that may be because they did PGD, or that may be because they wanted to get on and get off they wanted to get off the endocrine therapy fast and then get back on quickly because they didn't want to be off for too long. So we are dissecting those data right now. We did get a sneak peek at those data. So 43% used some form of ART, and a substantial minority actually, but it's a minority, did stim while they were survivors. They probably did, the majority, if they did bank eggs or embryos, they did that pre their treatment, like we do conventionally, but a small and measurable minority did it, like a substantial, not even that small. I think it's like 62 patients, but just between us, we haven't totally cleaned it up yet. So it's probably like 10%, give or take, did use ovarian stim during their survivorship period. So we'll have some data on that and the safety of that. We're looking into all of that. It looks okay, but it's, again, it's and you can't get totally away from the healthy mother bias because it's, it's still women that got through their first 18 months, no signs of recurrence. So it's not the early bad actors. You can't use this to say, oh, well, let's do it earlier, and because these are women who already got 18 months of therapy. If you have a really, really bad early recurrence, those people are gone from this. They wouldn't have gotten on this study. It was all ER positive. And then the majority were stage 1 and 2, which is the majority of this group, when they're diagnosed.
Right. Thank you so much. That was my second question. So if you knew how many patients had used their cryopreserved oocytes, so you answered that. So thank you so much.
We don't know how many used what they had. We just know that people, 43%, so close to half, used some form of assistance. It was probably the majority of that, but we don't know. We don't know if there was Clomid only or IUIs. We don't know what they were using.
Right.
We will know it. We recorded it. We just don't have it yet analyzed.
Yeah. Thank you so much. This was great.
Yeah, so Anne, I was thinking about with that 2-year period that you allowed for them to conceive, you stated that, after 1 year, evaluate with the REI physicians. And I wonder if you'll move that down to 6 months. I mean, we tend to tell people if you are over 35 or you have any concerns for infertility, maybe after 6 months, you might want to pull the trigger.
Totally agree with you. And, it wasn't, we talked about that. I think we had to be respectful of what people were like, what were country norms, what was acceptable, what might be covered, what people were comfortable with. But in my practice, I totally agree with you. And I think as we start to talk more about this, and we actually have looked in our young women's cohort, and and I have a young OBGYN resident actually looking at these, and she presented at San Antonio and was writing a paper, and we think that we agree with that exactly, and that's going to be, we're with you on that. I don't know if there's guidelines around that, but I think that's where we're all heading, because if you're not pregnant by 6 months in this group of patients, A, they're older, B, they've been exposed often to chemo, then they really should get in there and get help from you guys. And then we just need the insurances to follow suit, right? Because we don't want to be lying or gaming the system, right? I always tell people, well, tell them you've been trying, but if they see you were being treated for breast cancer, I don't want them to be lying or get in trouble or causing, fraudulent.
Yeah, it should fall within those guidelines of at risk for infertility, which those patients for any reason should proceed after 6 months. So it should fall within that.
Good.
All right. Are there any other questions from our 31 participants? No. Well, Anne, I want to thank you again. This was fantastic. I think we all have been wanting to hear this information so that we can modify our practices accordingly. And of course, obviously, you're not recommending that we do so necessarily based on the data just yet, but I know some recommendations will come out. But we really appreciate you taking the time to speak with our group. And for those of you on this webinar will be available on the Oncofertility Consortium website, so you can share with your colleagues. We tend to have about 30 to 40 individuals who listen, but then over 100, 200 who then log on to hear the webinar later due to hours. So thank you.
All right. Thanks,
All
everybody.
right. Take care. All right. Bye-bye.
Take care. Bye-bye.